Hi, everyone. Just watching numbers rolling in, so allowing everyone to join, and we'll start in just one moment. Okay, I think we'll go ahead and get started. Good afternoon, everyone, and welcome to our webinar on the Inflation Reduction Act, known as the IRA. I am Sally Warner, the CEO of the Cancer Support Community, also known as CSC. In 1982, our founders started CSC with the goal of creating a community to provide social and emotional support to cancer patients and their families and friends, all free of charge. 42 years later, we have grown to be a nonprofit network with nearly 200 locations, delivering more than $50 million in free support and navigation services to patients and their families across the globe. You can learn more about our work and programs at cancersupportcommunity.org. In the next hour, we'll be hearing from experts about the IRA Medicare Drug Price Negotiation Program and how advocacy organizations, healthcare providers, policy experts, and other stakeholders like you can collaborate to ensure patient voices are amplified and heard as the program is implemented. We will have an opportunity to engage in a discussion and take questions from our live audience during the latter half of the program as well, and we look forward to your participation. Today's webinar is part of a broader series of programming around the IRA that CSC launched in 2023, with the goal of convening experts, advocates, survivors, and caregivers for discussions about the need to ensure that drug negotiations in Medicare include input and perspectives from those who will be most impacted. We are proud to facilitate these discussions and appreciate you for participating and collaborating with us in this challenging but important work. Before we begin our official program, I want to thank a few people, including our live and on-demand viewers, for joining us for today's event and taking the time to understand how we can help ensure that patients, survivors, and caregivers' perspectives are prioritized during the negotiation process. On behalf of CSC, I would also like to thank all of our guest speakers today for taking time out of their busy schedules to participate in the program and share their perspectives. Our presenters today will include our very own Cheryl Corin-Bonder, an incredible CSC patient and advocate. We are so grateful to have her here to share her diagnosis and treatment story with us. We will also hear from Sara van Geertruyden of the Partnership to Improve Patient Care and Gretchen Wartman of the National Minority Quality Forum. I also want to thank my entire CSC staff who have worked so hard, directly involved in planning today's events, and others on the IRA consortium. The work we do for cancer patients and their families wouldn't be possible without you, and I'm grateful for all that you do. Lastly, thank you to our supporters, Gilead, AbbVie, Bristol Myers Squibb, and Merck, for helping to fund the important work that we do. With that, I am excited and thrilled to listen into the conversation today with you all, and I will now turn it over to Deneen Ciccone, who will moderate today's conversation.
Thank you, Sally, for introducing our event today. As Sally said, I'm Deneen Ciccone, Vice President of Policy and Advocacy at CSC, and I'll be moderating today's conversation. Thank you for joining us for our webinar on the IRA. Before we jump into the discussion, we want to remind everyone why we are here today. Congress and the Biden administration passed the Inflation Reduction Act in August 2022. Amongst a much larger series of policies, the IRA established the Medicare Drug Price Negotiation Program, empowering the Centers for Medicare and Medicaid Services to negotiate directly with pharmaceutical manufacturers for the first time. The drug negotiation program kicked off last September when CMS announced the first 10 drugs eligible for negotiation. CSC got involved around the implementation and rollout of the program because we recognize how important it is to protect and promote patient, survivor, and caregiver perspectives when it comes to access to prescription medications, particularly for complex conditions like cancer. Last September, we hosted the first CSC IRA Stakeholder Engagement Summit to discuss the importance of prioritizing the voices of patients, caregivers, and people with disabilities during the drug price negotiation process. In March, we published a manuscript recapping the conversation we had at that summit and debuted new principles for patient-centered engagement. We're proud to say those principles were developed in collaboration with diverse patient and provider stakeholder communities, including some of you on this webinar today. The manuscript includes research on the impact of the IRA negotiations on patients and our recommendations to improve the patient engagement aspect of negotiations by, among other things, defining clinical benefit, collecting meaningful data and real-world evidence, and engaging patient advocacy organizations, patients, and caregivers. And we shared these results with CMS. And all of this work that we have done, there is broad consensus across the communities we serve and partner with on the need for CMS to reevaluate their patient engagement goals within the negotiation process. These are just some of the issues and perspectives that we'll dig into over the next hour as we explore how CMS can better prioritize patients. So a few housekeeping items before we begin. First, a friendly reminder for our live audience before we begin our official program. Everyone on today's webinar is in listen-only mode, but you can use the chat box feature to submit questions to our speakers throughout the program, and we encourage you to do so. You don't have to wait until the end of the program to submit a question. So with that, we're going to get started. So I'm really privileged and honored to start off our program by introducing Cheryl Corin-Bonder. So we have invited Cheryl Corin-Bonder to start the conversation, as Sally said, by sharing her personal patient story and perspective. Cheryl is a survivor of acute myeloid leukemia, a rare blood cancer. She is now a patient advocate with CSC for others impacted by cancer, and last year she published a book about her cancer diagnosis. Cheryl, thank you very much for joining us. We're excited to hear your story today, so I'm going to turn it over to you.
Okay, thank you very much. I'm very pleased to be a part of this panel, hoping for the very best to come out of it. My name is Cheryl Corin-Bonder, and I am a New Jersey certified elementary school teacher. I am a certified health and wellness coach. I have planned and developed programs for breast cancer and ovarian cancer awareness programs. And in 2013, unbeknownst to me, I had a rash actually for probably 12 years prior to 2013. So whatever that year is. And I went to see the chief of dermatology at NYU, and he just was taking blood work every 3 months to find out what this was. It turned out a diagnosis of urticaria vasculitis, which is just an inflamed hive. And he checked ferociously for anything else. Lupus, I mean, they checked me for everything and nothing showed up until one day something did. And he suggested I go see my primary and have repeated blood work done. At that time, I was then told I needed to see a hematologist. Leukemia was the last thing out of my mind that I could ever possibly have had. I really, at that point, didn't have any symptoms. I was feeling well. I had just gotten off a golf course playing in 104 degrees, 18 holes, walking, and I couldn't believe that somebody was telling me that I was this sick. I went to see with friends, thank God for them, several hematology oncologists in New York City. I went to several academic medical centers, and each doctor there said I would need to have a stem cell transplant, or my chances of survival were probably 2 years or less. We walked out of there comparing our mental and written notes, and aside from all the tears streaming down our face, really could not even believe what we heard. I felt completely healthy. And I saw 4 of them, and I just assumed, okay, I'm going to have a stem cell transplant. It was the first time I ever heard of one. I didn't even know what was involved in a stem cell transplant. And my girlfriend said, let's just go see this one more doctor. I didn't want to go see any more doctors. They all seemed to say the same thing. And very callously, I have to say, we were talking about my life, and they were talking as if I had a hangnail. So we went to see this one other doctor, and she said to me, there is this new, my case was very complicated, and there is a new, excuse me, a new doctor that's gotten a lot of buzz at Weill Cornell. Why don't you just go check her out? I didn't want to go check her out. I had enough. I wasn't going to see one more doctor until my girlfriend just convinced me, who basically saved my life, just this very, very last one. So we did. We went to see her, Dr. Gail Robos, and she was an amazing person. She calmed my fears. She found humor in what was a ridiculous way or possibility to find any humor in a situation as dire as this. And she really relaxed me, giving me all the details I needed to know about a stem cell transplant. I had the stem cell transplant. I went home. My daughters, I have 2 daughters, they were 25 and 22 at the time. No, 21 at the time. They're 5 years apart. And they each took a leave of absence from work and were with me for an entire year. Once you have a stem cell transplant, you can't be released from the hospital until you have 24-hour care. They were amazing. I couldn't have done it without them. I came home with 31 pills that I needed to take. They learned how to do infusions, and it was, needless to say, the most difficult, heartbreaking experience I had to endure. And really not as concerned about my life for myself, but to have my young children, have to bear that burden was heartbreaking. As time went on, thankfully, I did very well. Until about 5 years ago, I was failing, going south very quickly, and my doctor had tried a whole vast of medications. One in particular was Jakafi. I had a very difficult time getting the medication. It was completely unaffordable for me. It was something like $30,000 for a pill or something. And I was able to get assistance from the Pan Foundation, luckily. I don't know how I was able to get it, because now when I do try to get assistance, financial assistance, they look at my financial picture. I'm not wealthy by any means. I'm a single parent. I'm divorced. And I have alimony as my only source of income, and I get that whenever he decides to give that to me. So I need the financial support, and I was denied every time. I had 12 different types of resources, and I was denied with each one. Thankfully, the social worker at the hospital really helped me. I contacted the pharmaceutical companies and asked for financial assistance. They also gave me the same story about they would only apply any financial assistance if I was below the poverty level, which I was not. So that was really a difficult thing. My doctor who thankfully thinks out of the box, found a new experimental drug. It was not approved and not taken by anyone. She said it was only tested on labs and on mice in a lab, and that was all that they had to go on. It looked like it had followed the pathway of my disease based on whatever precision medicine doctors had been able to find. She said, I can try it. I don't know if it's going to kill you, cure you. I don't even know what it's going to do for you. And I did try it because I had no other resources at all to fall back on. And within 6 weeks, miraculously, I was put in remission. I was on that drug for 4 years. No one else has been on that drug that I'm aware of in the world. I was initially diagnosed with a myeloproliferative neoplasm, and then at that point had turned into acute myeloid leukemia. And so you shouldn't have any blasts in your cells, in your bone or blood marrow, in your bone marrow or in your blood. I had 46%, which means my body was shooting a lot of blanks. I was void of whatever nutritional needs you need to function. This drug, this experimental drug, brought me down from 46% to 0. It was really pretty miraculous. At that point, I reached out to NIH and other cancer organizations, sharing my story, hoping for more research funding, hoping for more assistance for medication. And everyone said, wow, what a remarkable story. I'm so happy to hear that you're doing so well. No one came up with any money. So after that 4 years, a lot of these drugs don't really hold their efficacy well. So I, again, was facing, what do we do next? She recommended another chemo drug on top of the Inqovi, which on top of the Jakafi, which is called Inqovi, also an incredibly expensive drug, which I could not find anywhere anybody would help me out with. I have it, I'm taking it, and I spent, I don't know how many thousands of dollars on medication that I really didn't have to spend. And now I'm in the catastrophic phase of my health insurance through Medicare, which will only take me until December. At December, I will then have to face again the ongoing battle of pleading for someone to help me for this medication. If I don't have this medication, I'm going to die. So I even reached out to the White House, President Biden, when he opened up his cancer initiative with billions of dollars involved in that campaign. I didn't hear back from anyone. I spoke several times to public relations departments. I wrote emails. I sent letters. And again, I reached back out to the pharmaceutical companies without any assistance. So I'm here today, gratefully, thankfully. I am still on Inqovi. I have no idea how much longer that's going to last. I don't know what's going to happen when my insurance at that time in December decides to not help me cover the medication. And it worries me, and it increases in tremendous anxiety, which is not great for a disease state.
Thank you, Cheryl, for sharing your story. Very impactful. And I remember when we initially talked and you shared your experience, your story with me. One area that you said kind of kept you going with your daughters was humor. And I know I noticed you got a little emotional when you thought about, your daughters took a year leave of absence, to spend time with you. But I also remember you saying that having them with you, and your daughter, like, making drawings and, just keeping that humor and giving you that hope is what really helped to move you forward and keep you going. And I want to say that we thank you very much, sincerely, for sharing your perspective. We are grateful that the medication that you are taking, the tablets, are working, and are with you, and hoping that you can continue to have access affordable access to this treatment. So thank you so much, Cheryl. And with that, I would like to introduce Sara van Geertruyden, the Executive Director at the Partnership to Improve Patient Care, or PIPC. Sara is a healthcare and welfare policy expert with over 25 years of experience. She's been with PIPC since 2011, and her work focuses on policies to advance a patient-centered health system. Sara is an expert on the processes used to determine value and evaluate prices during the price negotiation process, and we're grateful for her continued engagement with CSC's work around the IRA and price negotiations. Sara, thank you so much for being here with us today, and I'll turn it over to you.
Thank you. Well, Cheryl, you're a hard act to follow. That was really beautifully stated. And I think, from PIPC's perspective, and I'm sure from Gretchen's, like, this is why we do what we do. And, as PIPC, just to give a little background, the Partnership to Improve Patient Care, we're a coalition that was started back in 2008, 2009. It was when this issue of comparative effectiveness research was sort of the hot topic on Capitol Hill. Some of you may remember that. There was a process by which, some funding was given to prioritize, what should we be studying? And then it eventually led to the creation of the Patient-Centered Outcomes Research Institute. And PIPC was very much involved in sort of the legislative process that created PCORI, arguing that, we should get beyond token engagement of patients and people with disabilities in this process, something more than, as Tony Coelho, who, for those of you who aren't familiar, Tony Coelho is the chair of PIPC, and he was the original author and sponsor of the Americans with Disabilities Act and has epilepsy himself. And he often talks about, when he talks about token engagement, he calls it, the Jerry Lewis syndrome. You pat people on the head and then to put them off the side and say, we'll take care of you, and that was really, our mission and vision for PCORI was that we would, that patients and people with disabilities would have a bigger role at the table, so that, we have 3 seats on the board for patients and people with disabilities now at PCORI, and patients and people with disabilities are there to inform what kinds of studies they fund. Because prior to that, the concern that I often heard from patients before PCORI was created was that they felt like the research wasn't necessarily on things that impacted how they made decisions about their own care. So I heard that a little bit, Cheryl, I think, in what you were saying as well. So anyway, so that's just some background in terms of how PIPC came to be, and now, we've taken that experience and we've sort of used it to push CMS and other agencies to continue to go down this path of more meaningful patient engagement. Another big piece of the statute that created PCORI was a provision that barred the use of a measure called quality adjusted life years in Medicare. Quality adjusted life years, for those of you who don't know it, are measures of cost effectiveness that typically devalue a person with disabilities in terms of what the value of their life is in a year when they're calculating cost effectiveness. And so it's a measure that there's been a lot of controversy with. It is now barred from use in Medicare. And as the negotiation process was happening, there's also now a provision in the law that created the negotiation process that says that CMS is not allowed to use measures of comparative clinical effectiveness research that devalue disabled lives. And then following that, just recently, were new rules created. The Section 504 of the Rehab Act is the law that governs disability discrimination. Those new regulations also call out that any entity that gets federal financial dollars is not allowed to use these types of discriminatory measures in their decision making. So a lot of work has gone into sort of making sure that the evidence base for decisions being made by payers around coverage and reimbursement don't devalue the very lives that they're intended to help. And so that's some of the stuff, that's a lot of the work that we have brought here to the negotiation process. And I will say, in terms of patient engagement, we as PIPC, following the creation of PCORI, Also, we're very deeply involved in trying to push for the Centers for Medicare and Medicaid Innovation, an entity that creates alternative payment models to really engage robustly patients to think about, well, what are going to be the patient-centeredness criteria called out in statute that you are going to use now to evaluate these new payment models? We haven't gotten much on that, but that was way back in 2014. And so I'm just kind of fascinated that we're still having this conversation. We're having it maybe in a different context, but still having it. We've had this conversation a lot in the context of P&T committees and drug utilization review boards at the state level. You know, what those boards will often do is contract out with a third-party entity to make recommendations about preferred drug lists, which then translate into decisions around coverage that frankly make it really hard sometimes for patients to get access to care. And we don't know what's going into those decisions because the third-party entities, the information that they use is proprietary. I think we all feel quite certain that these kinds of quality adjusted life year types of measures are going into those decisions. But the lack of transparency has been really difficult, and it is something that we hope that these new regulations will help us to kind of get up a little bit more under the hood. So I know today's discussion is focused on negotiation, though, and just want to highlight some of the work that we at PIPC have been doing on that. You know, first and foremost, you know, we just came out with a white paper that I think is being shared in the chat function. We tried to pull together some of the recommendations from across National Health Council, PCORI, and others around what good engagement looks like. I think one of the things that I would point out in the negotiation process that we're really focused on is how they do bring patients and people with disabilities into the discussion around, you know, what is the unmet need? What are the therapeutic alternatives? What represents a therapeutic advance? And making sure that they don't fall in conflict with the laws governing non-discrimination and not using those kinds of discriminatory measures. One of the things, too, though, that I think we're concerned about is that in this process, we still don't know what evidence they're using. So we've been very focused on, my understanding from CMS is that I think they're going to give patients more of an eye under the hood in March of 25 with regard to these negotiation decisions. So maybe there will be some information shared at that point about the evidentiary basis for those decisions. But at this point, we don't really have any idea, and it doesn't sound like the patient groups have really been in there to help them understand the quality of the evidence that's in front of them, which is, I think, which is, you know, a bit of a challenge, I think, in terms of trusting those decisions. And then another piece of this that I think, you know, I know a lot of folks are concerned because of that, what impact this will potentially have in terms of unintended consequences for patients to access all of the drugs that they may need. And is there going to be an engagement process? So one of the things we're really pushing to is that there needs to be sort of an ongoing engagement process throughout the life of this program to make sure that to the extent that there are any access challenges presented to patients, that CMS is learning about it and understanding it in real time, and that we're not addressing it years later when too many patients have been impacted. So you know, we want to be part of this, you know, discussion around process, and hopefully, you know, I think hopefully some of the work that we're doing is helpful, and I'm happy to answer questions about it. And then the second thing I would highlight from PIPC's perspective that we've been engaged in with regard to the negotiation process is looking at those. We often get the question, if you're not going to use these quality adjusted life years or QALYs, then what are you going to use? So we just recently did a project looking at all these other types of measures. I'm not going to walk through each and every one of them, but suffice it to say that there are other cost effectiveness analysis measures out there. There has been some innovation in the market on those, but at the same time, what we've learned and what we have found is that each one of those comes with trade-offs, right? So I'll use one as an example called the equal value life year gained. This is a measure that CMS and state prescription drug affordability boards and others have talked about using as an alternative to the QALY. What the equal value life year gain measure does is it doesn't have the discriminatory element in life extension, but it also doesn't value quality of life improvements. So you're sort of making this trade-off. You're gonna value then treatments that extend life, but not necessarily treatments that improve quality of life. And what we've found is that with almost all of these measures, there are those kinds of trade-offs. You're either valuing disability more and then more common conditions less, or life extension more and quality of life less. So there's really no one size fits all type of value measure that could be used that would represent all people, because they all kind of come with trade-offs. So the important thing here is just to know what you're getting into and to understand what these measures are and where those trade-offs are. And that's something that we've done a little bit of work on, because we know that advocates are getting those kinds of questions. But in conclusion, I'm excited to be here. I'm happy to participate in the Q&A. I think that this is going to be a long road ahead in terms of negotiation. I think there's a lot of lessons to be learned in terms of engagement and what kind of evidence they're using to make decisions. And our hope is that we can be part of that discussion and provide, some help to make sure that it is as patient friendly as it can be.
Absolutely. Thank you so much, Sara. And a lot of what you said is really consistent with cancer support community's patient-centered principles on engagement related to the Medicare drug price negotiation program. As you know, you're one of the co-authors of that manuscript. And there was one area that you didn't mention that I would love for you to talk to a little bit more. One of your recommendations to CMS with respect to ensuring patient-centeredness and patient engagement, most recently with respect to listening sessions. I recall there was a recommendation, if you could speak a little bit more about maybe creating a continuous loop for diverse perspectives, continuous engagement opportunities, and even the creation of an ombudsman, right, to work with patient advocacy organizations, patients, and caregivers. Could you just talk a little bit more about that piece? Because I think that's a really great concrete example and action step that you all recommended.
Yeah, I think this is the challenge, right? When you're in Washington, D.C. and the folks in the agency and you know who to call, you know how to get access, not everybody has that. And so one of our recommendations has all along been creating some sort of ombudsman role at the agency that would be kind of a one-stop shop for patients and people with disabilities who want to enter into the discussion, provide feedback, schedule meetings, understand how to participate in the process. CMS doesn't really have that sort of role embedded in any part of the agency, frankly. So that's something that we've often pushed. And then in terms of the continuous feedback loop, I think that kind of gets to the issue I was talking about earlier. They had these engagement opportunities. It was kind of a once engagement opportunity for each drug that they're reviewing, as opposed to meeting with patients once and then saying, okay, here's what we're looking at. What do you think? And having sort of this back and forth conversation. And I think that's the kind of engagement that we're hoping to see going forward, is more of this, okay, here's what we're looking at. Can you give us your feedback? What do you think about these sources of evidence? Are they, what do you think about the quality of the evidence and how it was pulled together? And the reality is that patient groups really understand these evidence sources pretty well. We have a lot of concerns that a lot of these cost effectiveness measures, the sources of that go into them are often not diverse, right? So you have a tremendous lack of diversity in the data itself. We've always argued that really the place you want to make an investment is in the data, right? We need more and better data about what the real world experiences are of patients and people with disabilities. And Cheryl's story to me is a great example of a person whose experience has not yet translated into the research literature, right? So the only way you're going to know her story is for her to tell it to you. And that's really important. And there need to be opportunities for those stories to make it to policymakers.
Absolutely. Couldn't agree more. And with that, last but certainly not least, we will hear from Gretchen Wartman, Vice President for Policy and Program at the National Minority Quality Forum. She is the director of the Institute for Equity in Health Policy and Practice and the director of the National Alliance for Brain Health and Awareness. Gretchen has extensive experience in health policy analysis and has been with NMQF for over 20 years, working toward the goal of reducing patient risk and advancing health equity by assuring optimal care for all. Gretchen brings a valuable perspective on how the Medicare negotiations may hinder progress that we've made towards health equity. And so with that, Gretchen, I'm happy to turn it over to you.
Well, thank you, Deneen. And I also want to acknowledge Sara, who was one of the first individuals I met when I started working with the National Minority Quality Forum. CSC is a relatively new partner. Sara had the task of introducing me to even the concept of qualities. And listening to her, excuse me, this afternoon reminds me of how clear and direct a communicator she is in an extraordinarily sort of dispassionate way, but also in a balanced way. So my thanks to all who enabled me to present today, and thank you, Sara. For continuing to provide this kind of leadership on these extraordinarily complex issues. For those who, I won't repeat and any of Deneen's introduction other than to say thank you for being so complimentary. I do want to take a moment to introduce members of the audience to the National Minority Quality Forum. If you are not aware of us, we are a 501c3 not-for-profit research and advocacy organization that is based in Washington, D.C. We are committed to the transformation of America's legacy healthcare, finance, research, and delivery constructs to a system that embraces as its prime directive the prevention and reduction of patient risk and the assurance of optimal care and outcomes for all. The Institute for Equity in Health Policy and Practice is a curated collaboration that supports members' efforts to advance equity in a manner that is responsive to the health concerns of all population cohorts within the context of essential business imperatives. The Institute facilitates the exchange of information, supports educational efforts, and undertakes consensus-building initiatives that focus on forward-looking policy and regulation. We also advance the following pillars of equity: a system of care that assigns the highest priority to patient risk mitigation while recognizing the imperative to address financial risk mitigation. Treatment and payment paradigms that provide clinicians with maximum flexibility in responding to patient needs. Research designs that assure the statistically significant and robust inclusion of all population and patient cohorts. And enhanced data collection, monitoring, and evaluation of the outcomes associated with promulgated policy and regulation. So when I was trying to summarize who we are in a nutshell, or four, I think, I would say that we are proactive and cautious. We are pragmatic and visionary. We are therapeutic area agnostic, and we engage when and where we have opportunity. Which brings me to the topic of this discussion this afternoon, which is the recent requirement, relatively recent requirement, that Medicare negotiate prices for certain high expenditure drugs, which is fraught with potential risks and benefits. We are all here today because of our concerns that failure to provide, I would say, empowered leadership and engagement with CMS will further enable the potential for this new process, relatively new process, to exacerbate harms that are built into the legacy system. Through the patient-centered lens, we all bring many therapeutic area and identity lenses to this IRA drug price negotiation paradigm. Oncology, sex, gender, cardiology, race, rheumatology, LGBTQ plus identity, geography of residence, endocrinology, neurology, ethnicity, psychiatry, to name a few. The point is that I'm making here is that we all have overlapping layers of identity that are too readily translated into and can be codified into disparities, inequalities, and inequity. The National Minority Quality Forum, by virtue of the population cohorts we represent, are first, foremost, and always patient-centric and intersectional. We must be. So must those of you who enter through the lens of a particular therapeutic area. It is perhaps comforting, but I would submit delusional, to believe that we can focus on any one identity that defines us and turn a blind eye to the others. More directly, if you believe you are safe, if you believe that the system assigns value to that which you bring to the table because of your phenotype or diagnosis, which has traditionally been favored by the structure, I don't believe I can disabuse you of that belief this afternoon, but I strongly encourage you to examine your positioning through a wider lens. Identities and vulnerabilities overlap. No patient, no community, no population has a safe harbor if others are under duress. This, I think, we all know. So in closing, I'm not sure where I am in my 10 minutes, but I want to leave as much time for discussion as possible. I'd like to put a few recommendations on the table that we can discuss to maybe help guide our interaction with CMS on this issue of drug price negotiation. One is that we take steps to ensure or to assure that CMS is factoring in differentials in disease risk and prevalence, in access and in equity when identifying the therapeutic equivalents that will inform the drug price negotiation process. Now, I've spent a fair amount of time working my way through the guidance that CMS has issued for manufacturers. It is compound complex at best. It is not written in a way that readily enables those who are not a part of those processes inside the biopharma industry to grasp, hence the value of the Saras of the world. But I will say that that is not an oversight. What Sara also spoke to is the fact that CMS is not enabling through through any of its processes, through the guidance, it is not enabling valued input from the beneficiaries who are, in our view, their primary audience. It is their reason for existing. And we need to help them remember that as they move forward. So we would also, as a second recommendation, encourage CMS and others, including the state processes that Sara referenced, to put patient and community risk reduction first, to model potential impact and to make the long-term commitment to monitoring, evaluating, and reporting the impact of the decisions they make through these value assessment, drug price negotiation, price setting, if you will, processes. And third, more specifically, to eliminate differentials across types of interventions within the orphan drug universe, or small molecules versus large molecules. Those kinds of conversations are occurring within CMS as part of this drug price negotiation process. And we all need to work together to assure we know what that means for the therapeutic areas and the populations who are of particular concern for us. We strongly encourage that we collaborate, to ensure that CMS makes the commitment to course correct if and when they find that harms, new harms, old harms, are being created or exacerbated through this drug price negotiation process. And if that means finding ways to require perhaps a slowing of the process in the interest of reducing the patient risks, finding a way to do so. And I say that way because we do recognize that the payer world and others have business models that focus on financial exposure, minimizing their financial exposure for the role that they play in health services, research, delivery, and finance. But if they put us at risk, then for me, it begs the question of whether or how the mission of research, delivery, and finance has migrated away from the patient and to the business sectors who should be enabled, because we cannot function without pharma. We cannot function, as our society is defined, without an insurer and payer, a world that enable us to have financial access, physical access to effective therapies. But if we are an afterthought, or in a document that I read a number of years ago, that's probably still in my office, as Uwe Reinhardt described us as simply an opportunity for a billing, and he wasn't being unkind. He was reminding us that the role of the patient essentially triggers activity, but absent a concerted attention, we may not be the object of the outcome of that activity. So I'll stop here. I encourage us to have as robust a conversation in the time we have left to identify ways we can align around our strengths. And I thank you, Denise.
Thank you, Gretchen. Those were powerful, powerful remarks. And what came to mind for me, what we always say, each unique patient, each unique experience matters and should be factored in the determination process, and cost effectiveness and value. And that's what you did, particularly when you talked about the intersectionality. That can so often be forgotten. We're not monoliths, we're complex, and what might be valuable to someone, person A, that drug may have a different, or that value to that drug may be different or present differently to person B. But both perspectives are important, their feedback are important and should be considered in that process. And I love what you said about the continuous loop, particularly as it relates to monitoring for harms and being able to adapt and respond quickly. And as you said, in some cases, slow down, quite frankly, the process if need to be, to continue to keep the patient at the center. So with that, Gretchen, I want to say thank you. And we have about 10 minutes left, so this is great. And so I just want to say thank you again to all our presenters, Cheryl, Gretchen, and Sara, for sharing your expertise on these issues. So as I mentioned, we're going to open up the time now, excuse me, for questions. And if you have a question for one or all of our speakers, you can submit them in the chat box feature now. And so while you all are thinking maybe about a question to share, there is one that came through earlier that I'd like to share. So I'm going to ask it now for the group. A lot of concerns, rightfully so, focus on equitable access to existing drugs and treatments that might be harmed by the IRA. What are your thoughts on potential consequences for the development of new drugs and treatments? Is there a risk that innovation will be harmed, resulting in fewer new drugs and treatments becoming available for patients? Who'd like to take that?
I'll give a quick answer, which is yes. I'm very concerned. Because as Sara pointed out, and I think what we all need to remember, that we need to be identifiable and visible during deliberations, regardless of whether they're public comments or the behind the scenes deliberation. And what this process risks doing is constraining access to certain therapies or that are essential to support the health of populations who are devalued by virtue of the way our society is structured. And by sort of embedding that invisibility into the process in a way that supports and enables increased marginalization of these population cohorts. So I'll turn it over to Sara if she wants to add something to that.
Yeah, well, Gretchen, how much I love listening to you talk, because Gretchen seems to have a knack for being able to put this in a real world context in terms of how patients are really impacted. So I want to just say though, I think I come back to this in terms of the impact on innovation from the perspective too of just, we don't know what the impact is going to look like in terms of utilization management strategies used by payers that relate to both the drugs being negotiated and other drugs in the class. And that's part of why we're really pushy about wanting to have this feedback loop, right? Like the engagement process can't just be this one-off thing that you just do once, right? It's got to be something where I think what we're looking for is like, okay, what's the feedback loop look like? How are you staying in touch with patients? How are you making sure that they're still getting what they need? And at the moment where they're not, what are you doing to address it, right? I mean, that's, I think, the piece that we're all looking for that we haven't really seen yet. Yeah, because as Gretchen so, more eloquently than I did said, I mean, the information coming into the agency is not particularly representative of everyone, particularly the differences that they have in terms of access. I mean, we embedded all these provisions into PCORI statute to make sure that they didn't PCORI's not allowed to come out and say drug A works better than drug B or treatment A works better than treatment B. What they do is they say, these treatments work better on these people and here's why. And these other things might work better on other people and here's why, based on who they are, where they live, and all of those different identities that Gretchen described. That's kind of built into PCORI statute. That wasn't really built into this statute in that defined way, and I think that's what we're looking for from the process and the regulations or the guidance.
Good point. So to build off of that, I'm going to open this question up. Maybe Sara, you can start, and then Cheryl and Gretchen can chime in if they want. What is the most important way for patients, survivors, and caregivers to engage with CMS on this process?
It's a good question. I think last time, everything that the feedback we've been getting from the patients and folks that had participated was just that it didn't, I hope it's better. I mean, I think going forward, the plan has been just, to do these one-off engagement activities. I think, in the initial set of guidance, they put out some ideas for other ways that they could potentially engage patients and people with disabilities, but they didn't really define a process. But I think what they need is just to bring in they really should just bring in some patient groups who do this regularly, know how to do it, and help them set up a structure, right? If it were up to me, like, that's what I think they should do. And we talk about this in our paper, like just creating some sort of advisory group of patients that can come in there and help them do this and get it right, and use entities like PCORI potentially as a model, would be a great step in the right direction, right? Because right now it's unknown how to engage. And frankly, it's difficult for the patient groups to push their patients to engage if you don't understand what you're engaging in and why, and how the information is going to be used and where it's going to go. And none of those kinds of questions, at least in the initial process, like, it wasn't like patients came into those initial meetings with, here are the 3 questions, and here are the 3 things we want to know from you, because here's how it's going to help us in our decision-making. That didn't exist. And if you really want patients to get involved and to engage and participate in those kinds of meetings, they need to know what they're engaging in and why. And that's something that the patient groups know how to do. Anyway.
Cheryl, you're on mute.
I'm going to jump in here. As a patient, I certainly understand the frustration about not knowing where to go and who can help me. So in my past life as a program planner and program development for breast cancer and awareness program, which I thought that was going to have to be my worry in life, because I'm 4 generations breast cancer survivor. So I think where you really have to start is where the patients are being treated. Doctors don't even know about some of these support programs. Social workers at the hospital don't even know about these programs. So I think you really need to reach out to them, who can reach out to the patients to alert them, yeah, A, B, and C is available, and I'm going to not just give them the information, I'm going to recommend you. I'm going to make a phone call. They need to get involved as well to secure the involvement of the patients.
That's a great point. You're right.
That's my take.
I love that.
That's my take.
I love that.
I had offered, to work at CMS several times, to volunteer. I'm a coach. I've worked. I'm a facilitator for a support group presently. I know the trials and tribulations, and I know the journey. It's not pleasant, and unless you've walked in those shoes, you really don't know how to respond and how to assist somebody's incredibly sad, almost hopeless mindset. I developed a level of perseverance and positivity, and coming from someone who's walked that journey makes a big difference to patients.
Agreed. And I love that we are going to end it on what you said, Cheryl. We started with you, and we're going to end it with you, because everything that we do here as a community, it's for you, patients, patient survivors and caregivers, and those who you love, who are there with you through the journey. So I can't believe we're already at time, but here we are. I'd like to say, on behalf of the cancer support community, I want to thank again our wonderful panelists for their insights on this issue, and all of you who attended today's event. Looking forward, we are excited to see how this conversation continues at our 2nd annual IRA Stakeholder Engagement Summit this September. We'll hear from more experts in this space, including Sara and Gretchen, on 3 distinct panels to discuss updates on the implementation process, measuring patient and caregiver experiences, and the impact of the IRA on health equity. We're looking forward to those conversations and the outcomes and recommendations for CMS that will come out of the summit. We hope you found today's program valuable, and we encourage you to get involved with CSC on this issue as it continues to evolve. That concludes our program today. Thank you.
Thank you.
Thank you. That was excellent.